Hello, everyone, and thank you all for joining today. It's my pleasure to welcome you to this PQI Innovation webinar titled Transforming Maternal Health Model, a Blueprint for Maternity Care. My name is Kaylee Espinola, and I will be running the Zoom logistics of this webinar and introducing today's speakers. When I'm not providing tech support for PQI, I'm a Senior Project Manager for the Massachusetts State Perinatal Quality Collaborative. Couple of items before we begin. This webinar is being recorded and will be posted for free on the PQI website. There will be time for question and answer at the end of today's presentation, so please type any questions you have into the chat and we'll address them at that time. If you experience any technical issues, please feel free to send me a private message and I'll do my best to help. Now it's my pleasure to introduce today's keynote speaker. Carol Sakala, PhD, MSPH, led the maternal health portfolio at the National Partnership for Women and Families for nearly a dozen years. She is now a full-time maternal health consultant with the National Partnership, working on special projects, including the 4th National Listening to Mothers Survey. She is a nationally recognized maternal health and maternity care thought leader with expertise in maternity care system transformation and high-performing maternal care models. Carol led the 2 projects covered in this webinar, a playbook for both grantee and non-grantee state Medicaid agencies and their partners working to implement the Transforming Maternal Health model and a landscape study of maternity care alternative payment models. And now I'll turn it over to Dr. Deborah Bingham, who is the CEO and founder of the Institute for Perinatal Quality Improvement. Excuse my dogs. Thank you for listening and enjoy the webinar.
It's so great to be with you all today. And thank you for joining for this very important and informative webinar. And we're so happy to have so many here with us and more expected. So I'm the CEO and founder of the Institute for Perinatal Quality Improvement. And our mission is to expand the use of improvement science and in order to eliminate preventable perinatal morbidity and mortality and perinatal racial and ethnic disparities. Our long-term goal is by 2035 that we will have Speak Up champions will eliminate perinatal disparities in their organizations and communities throughout the United States. And we've made a lot of progress in this regard, but we have a lot more to go. So let me just give you a few ground us in this discussion today, why this work is so important, by going over a few key statistics. And then I'm going to give you little updates on some of the things we're doing at PQI, and then we'll turn it over to Dr. Sakala. So U.S. infant mortality rates are high and vary across the country. You can see that infant maternal mortality rates in the United States is about 5.4 per 1,000 live births, which is higher than a lot of other countries. And then what you can tell by the colors on this map that there's wide variation throughout the country. In addition, there is wide variation within all the states, within counties. And so it's a issue that we see primarily if we look at by race ethnicity, we see wide disparities in outcomes and infant mortality rates by race ethnicity, with Native Hawaiian or other Pacific Islander non-Hispanic, Black non-Hispanic, and American Indian and Alaska Native non-Hispanic people suffering the highest proportion of infant mortality rates. In fact, in states across the country, like Mississippi, there has been a declaration of it being a public health emergency because these rates have been increasing. And in Mississippi, they have their Black infant deaths were 15.2 in 2024 compared to white infants, which was 5.8. And you can see the graphs below showing this rise in infant mortality across their state. That's not unique to Mississippi. There are other states that are also seeing these increases. When we talk about pregnancy-related mortality ratios in the United States, we had a sharp rise due to the pandemic, but we can see that we've had the trend has been on an upward trend for a number of years, and there's still a lot of work to be done in eliminating perinatal related mortality deaths. And when we look by race ethnicity, we see that non-Hispanic Black and non-Hispanic American Indian or Alaska Native suffer also a disproportionate number of deaths. And so this is really important to highlight and point out. The data are telling us that we need to give more attention to these populations in order to eliminate these disparities. There is no physiologic, the reasons behind this are more structural than individual. So just to be clear about that. Now, more than 80% of pregnancy-related deaths, and it depends on the cause of death. Some causes of death, it's over 90% preventable. But, and I'm just gonna really, let that sink in, because that's really gives us opportunities for improvement, but that's also really difficult to really think about how many of these deaths could have been prevented. And so we have a lot of work to be done. And in fact, just recently, I don't know if you've all seen this paper that came out, but this, I'm going to highlight a sentence in this paper, and I recommend the entire paper to all of you. During 2018 to 2022, 2,679 pregnancy-related deaths could have been prevented if the national rate was reduced to the lowest state rate. So all of this tells us we're so glad you're here and that you're willing to figure out ways in which you can help fix this problem. And Dr. Sakala is going to give us insights into a big project, some big initiatives to help work on these problems. In addition, I want to just show pregnancy-related mortality rates per 100 live births. This shows that there's wide variation based on the state and location. And as a QI expert, I would say whenever we see this level of variation, we know that there are opportunities for improvement. So maternal deaths, infant deaths are only part of, or the tip of the iceberg. We also have seen higher incident prevalence of maternal morbidity, and these have increased significantly over the years. But these data do tell us that how one fares in the United States has been characterized by a racial division that begins at birth with disparities in healthcare. And we have a whole program. We don't have time today, but we have a whole program where we go through and unpack these numbers and provide education to help teams be better prepared to work to prevent perinatal disparities within their organizations. And it's called the Speak Up Against Racism program. The first level of that program is a Speak Up Champion level. And this is a 8-hour education live virtual course. And we have over nearly 2,000 people who have completed the Speak Up Champion course from a lot of different parts of the country. And you have the opportunity to attend this course. We have a course offered on January 9th and 16th, and we would love to have you join us at this course. So if you want to become a Speak Up Champion and be part of the solution, please join us. One thing I'll say about the course is, and we're a QI-based organization, so we spend, this course is grounded in QI principles. We talk about the problem, but we also help the participants leave the course with action plans of what they each personally can do. So it's a little bit different than some of the other courses you may have taken on racial implicit, explicit bias training. It includes that plus the QI component. We also have online modules that are also available, self-paced on demand. And this is the birth equity module is one of the courses we have. We have this, we also have 3 speak up modules as well. Other activities, we do offer QI Essential course. Our 2026 dates are to be determined. If you had a group that you wanted to take this course, we also do private events. We have a private event happening for the state of Kentucky at the end of October in 2025. So you can reach out to us to learn more about those if you wanted your whole team to get some QI skills and build the capacity to work on all types of QI projects. We also offer an intermittent auscultation online simulation-based course. We feel like we know the data show that increased use of cesarean section, or I should say overuse of cesarean section, has led to increased morbidity in our country, and that's highly preventable. And so we are expanding and encouraging the use of intermittent auscultation to encourage more active freedom of movement in labor. We offer these free webinars. Our next webinar will be in November, on November 11th, and you can register for that webinar here. And then our 2 most recent webinars that we completed was on race, racism, and perinatal health inequities, and labor and birth in people with excess adiposity, implications for clinical care. And those webinars are in our webinar library, and you can watch those for free. And we, as well as all of our other previous webinars, are all available on our website for free. The last thing I'll say before I turn it over to Dr. Sakala is many of you may know that I'm a co-editor of my son's book. My son tragically died unexpectedly due to disinvestment in public infrastructure. At the time of his death, his book was under peer review, and me and 2 of his colleagues from Boston University completed his book, and the book was just published just a few months ago. So it's still pretty hot off the press. And we're very grateful that we were able to get this book published. And there's a website there. 100% of our family's share of the proceeds go to individuals and nonprofit organizations based in the Mississippi Delta. Boston University School of Public Health, where David used to teach, did choose his book to be the community reads book for this fall. And last week, me and the other 2 co-editors were a part of a recorded panel discussion webinar that is now available online, and you can watch that if you want to learn more about the book. And so I think I wanted to point that out to you. You could then meet me and the other 2 co-editors on that, and we discussed the book more in depth. In addition, I want to point out, and I really, if you appreciate all the free things that PQI offers, provides you, one way to give back to PQI would be to help support our film projects. So this is the Create Ripples of Hope. It's based on David's book, and I am looking for donations for this book. It's more important to me right now. The number of donors matters more than the amount of the donation, because I am looking hopefully to show larger funders that there's a lot of interest in this book. And this documentary we have a short film, a 15-minute intro film about the book and about my journey. But the larger documentary project will explore 5 topics that affect health, each corresponding to a chapter in David's book. So it will be on foods, neighborhoods, jobs, education, and healthcare, and help explain to people about how context affects health. And just, I think there's so much misunderstanding, and I think books are great, but I also think a film would be very helpful in and having some educational materials that educators can use and individuals can use to help explain to people in their circle of influence. So please donate to this project. But without further ado, we're now going to turn the time over to Carol Sakala, who has been a dear colleague and friend of mine for a number of years. And I'm so honored that she made time to be with us today and to share her expertise about this really exciting new project.
Thank you, Deborah, for this opportunity to discuss the CMS Innovation Center's Transforming Maternal Health, or TMaH, model and supportive resources with the PQI community. And welcome to everyone who's here. We'll reserve time for discussion following this presentation. So this is a blueprint for better maternal health in both the states that are formally participating in the model and all others that are working for better maternal health. And there are some registrants from other countries as well. I feel that the framework would be very useful throughout many of these countries. Next, please. I'll be speaking about some related resources prepared through the National Partnership for Women and Families as well. The National Partnership is a nonprofit policy and advocacy group that works to improve lives of women and families. We work for a just and equitable society in which all can live with dignity, respect, and security and achieve their potential, while no one is held back by discrimination or bias. And we have two policy teams, health justice and economic justice, with maternal health being one of three health justice portfolios. Next, please. So I've been honored to work at the national and also state level on a broad range of maternal health and maternity care system transformation issues. And I was the lead on two projects that I will discuss today. First, a landscape study on maternity care alternative payment models that was released last year. And second, a playbook to support state Medicaid agencies and their partners in implementing the TMaH framework. The playbook was released this year. I want to acknowledge Megan Burns, my partner on both projects, and the Skyline Foundation for its support of both projects. And lastly, I have no conflicts to disclose. Next, please. So TMaH is a 10-year care delivery and payment reform model that began in January. And among applicants, 14 states and the District of Columbia were selected to participate and receive financial support and technical assistance. Each is required to support 10 model elements, and in addition, they could choose among 8 optional elements to pursue and were required to commit upfront in their application. As noted, the model has a lot to offer to many non-TMaH states working for better maternal health. TMaH begins with a 3-year pre-implementation period, which is followed by a 7-year implementation period. It's among the longest models CMS has developed, and we think that is fabulous. It reflects the long episode of maternity care, and the pre-implementation period provides an opportunity to shore up maternal health infrastructure for successful implementation. The length provides a chance to begin to create culture change with teams working together towards shared aims and steadily improving. And the length increases the opportunity to document better outcomes over time. And the URL on this slide is for the CMS TMaH landing page, where you can find more granular details of the model. Next, please. Here you can see the 15 participating jurisdictions. we are thrilled that many states that have traditionally lagged on maternal health applied and were selected. And this map relates to the maps that you showed, Deborah, as well. I would highlight the swath from Oklahoma to West Virginia as states that have traditionally lagged. And then the participants include states that have been leading on maternal health, which showed good performance on the previously shown maps, such as California and New Jersey. So the model will allow the leaders to continue to innovate and will enable learning and growth among those coming from behind. Next, please. So we've gotten behind TMaH and are encouraging funders, clinicians, advocates, and others to embrace and catalyze this opportunity, that is, to join in proactively because of its great potential. During this conversation and beyond, I encourage you to consider how you might become a TMaH model catalyzer in your own state. First, as we all know, we are failing to give childbearing families the care and support they need. And a Commonwealth Fund graph of maternal mortality among 14 OECD countries is instructive. We are highest among all with severe outlier racial and ethnic disparities. And even white US women alone have higher maternal mortality than all other nations. This tells me we need to address the disparities and we need to transform our system, and TMaH offers the potential to do that. What happens during this period has ongoing implications for all newborns and the 85% of women who have one or more babies. So this is about population health. Second, TMaH offers a comprehensive framework, and all participants are required to advance underused high-performing elements that many of us have long supported. These include increasing access to midwifery care, birth center care, doula support, accountable versus unaccountable payment, and whole person care, by which I mean meeting mental health and social needs as well as physical needs. And as mentioned at the outset, there's potential for spillover effects with the framework shaping practice in non-TMaH states. There's also potential to finally reach a tipping point for the high-performing, underused elements that warrant full integration in our maternity care system. Moreover, TMaH goes through Medicaid, which covers a full 40% of the nation's births and reaches a disproportionately harmed and challenged population. We're thrilled with the initial 3-year pre-implementation period, which, as noted, provides an opportunity and incentive to shore up state maternal health infrastructure. We can avoid less effective workarounds, for example, by licensing and providing Medicaid reimbursement for all 3 types of nationally recognized midwives. This pre-implementation period was a key factor in our development of the playbook that I will be discussing. To me, the ultimate goal is culture change. That is, having care teams work together towards shared aims and steadily improve. 10 years with more accountable care is an opportunity to begin to realize such change. And lastly, the constellation of participating states also gives me hope. Next, please. So I'd like to share a bit about why going beyond fee-for-service payment is critical for the change we need and the success of TMaH, as well as where things stand in the US with maternity care alternative payment models, also known as APMs. Our failure to leverage payment at scale for better maternal infant health is a major missed opportunity in this capitalist healthcare system. Fee-for-service payment fosters complacency. There's no incentive to consider whether one might provide better care or get better outcomes. And in fact, the incentive is to overtreat an essentially healthy population with services that may not be needed or wanted, and to offer lucrative services which may not be needed versus beneficial care that may be reimbursed at lower rates or not at all. And complications are generally rewarded with more revenue. By contrast, a hallmark of APMs is that a portion of payment is tied to accountability, such as whether the care provided was of high quality or whether good outcomes were attained. And typically, performance measures are used to assess care and outcomes. So upside risk involves sharing in savings from good care or outcomes, and downside risk, which is much less popular with clinicians and less used to date, involves decreased payment due to poor care or outcomes. And TMaH plans on using both types of both upside and downside risk. Over time, teams can shift the culture by working together towards shared aims with steady improvement. Next, please. So Megan Burns and I carried out a maternity care APM landscape study based on structured interviews with APM program managers, as well as birth justice leaders and national payment reform thought leaders. We focused on episode payment programs, which can improve clinical care, and on maternity care home programs to improve support services. And this is a specialized application of the patient-centered maternity care home in primary care. What we found was deeply disappointing. Very few such programs are being offered. Participation was largely voluntary and few providers were joining. So the reach was limited, and we estimated that only about 3% of US childbearing were receiving care within episode programs, and even fewer within maternity care homes. The older legacy programs were unable to report improved health over time, whether that is overall or through reduced inequity. And newer programs, which have been intentionally set up in recent years to address the now widely recognized maternal health crisis and inequitable care experiences and outcomes, it was too early to assess their results. Next, please. So for better scale of accountable care, we concluded that a central policy signal was needed. And as we were wrapping up our work, we learned that finally the CMS Innovation Center was developing a model to tackle the nation's maternity care crisis. So TMaH is that needed central policy signal. We also were not surprised about the lack of impact, as the program designs were very weak and were not carefully tailored to the circumstances of maternity care. There seemed to be a copycat phenomenon of repeating ill-advised choices of prior programs in and beyond maternity care. As a result, we have extensive recommendations for more tailored and impactful designs. CMS and its subcontractors, with input from the 15 grantees, are currently developing the TMaH payment model. We have shared our recommendations with CMS and many in the TMaH network and hope they do not repeat ineffective decisions of past programs. And this slide shows links to both our APM reports and the pullout files from those reports, as well as our Health Affairs Forefront blog with high-level takeaways from the landscape study. Next, please. This year, we released a playbook to support impactful implementation of the TMaH model. And the audience is very broad. Medicaid agencies in both TMaH and non-TMaH states, and their clinical community, state, and federal partners. many have a potential role in the success of this model. The playbook supports those tasked with carrying out this work who may not understand maternity-specific nuances of the various elements. So to return to the example of our complex midwifery landscape, they need to know that there are 3 types of nationally recognized midwives, which ones are licensed in their state, which are reimbursed by Medicaid in their state, the settings where each practices, and how best to build and support this workforce. We wanted to enable states to efficiently shore up their maternal health infrastructure during these first 3 pre-implementation model years. So users can see what their state has accomplished. They can prioritize among action steps that might be taken to build on the status quo and work with partners to prepare for successful implementation. Next, please. The playbook has 3 sections. The first is a set of basic policy principles with accompanying checklists. The second section, by far the largest, provides guidance for all required and optional model elements. And the third section is a design guide for the payment model that reflects what we learned from our APM landscape study and the resulting recommendations for more effective designs. Next, please. So the basic policy principles in the first section are improve quality through accountability, reduce outcome gaps, set expectations and progressively adjust goals, and generate maternity care practice culture change. And we have a set of checklists for each of these. As we were completing this work, the hot button issues in the current administration had become apparent. We didn't want to include language and content that would limit use or sharing of these resources. So we modified our language, and one example is reducing outcome gaps versus reducing inequities. Next, please. The second section is by far the longest at about 45 pages. It covers all 10 required TMaH model elements, which are listed here, and all 8 optional elements. I think you can see that with 1 or 2 exceptions, broader, more consistent implementation of these elements would be beneficial for childbearing families. The birthing-friendly hospital designation is an exception. At this point, virtually all hospitals with maternity services have earned this designation already. We shared our concerns with the previous administration. It's so easy to get this. It doesn't discriminate higher from lower quality facilities and is in fact misleading for people making care arrangements. There was an intention to add more criteria for the designation, and it's unclear whether this will happen. I also want to note that it's likely that the current administration will remove the health equity plan element. We did create this section, but pulled it out as a separate document, again, to avoid compromising use and sharing of the playbook in the present environment. Next, please. So here are 8 optional elements. States were required to commit in their applications, and I understand that quite a few did identify optional elements that they would work on during their participation period, but I don't have the details. Virtually all states have extended Medicaid eligibility to 12 months, although 2 TMaH states, Wisconsin and Arkansas, need to move forward on this. But generally, you can see that there's great potential in the optional elements as well to make a big difference for childbearing families. Next, please. So for all required and optional elements, the playbook includes the rationale and evidence for inclusion of the element to help stakeholders really understand their importance to the success of the model. We also discuss the current state, often clarifying where the respective states stand on such matters as licensure and regulation, Medicaid reimbursement, unneeded restrictions that could be removed for better access, and more. We also reproduce the milestones that CMS provided for the pre-implementation period, and we include a policy checklist of things that can be done to prepare for successful implementation, if not already accomplished. And we have both key resources supporting checklist items and endnotes with citations supporting statements in this guidance. Next, please. So the lack of demonstrated impact on APMs of maternal and infant health outcomes was deeply disappointing, but as I noted, not surprising. The designs largely didn't include features that could be expected to drive improvement. I've selected about a dozen examples of features that could be expected to drive improvement, but were rarely used, if at all, in the programs we examined. Our recommendations include others if you're interested in a full set. We hope the TMaH payment model, currently being designed and work across the nation beyond those states, will facilitate improvement through such measures as these. First, we examined clinical episode programs and maternity care homes because both clinical care and support are important for maternal infant well-being. And the two foci can be integrated into one model or can work side by side. Second, most programs only focused on the mother, whereas the fates of mom and baby are deeply intertwined. Excluding the baby, in my view, is very short-sighted and a missed opportunity to impact twice as many people and population health. We know that conditions at this time can have long-term, even lifelong effects on the well-being of both members of the couplet. It's important to heed growing lessons from such bodies of knowledge as the human microbiome, epigenetics, hormonal physiology of childbearing, and life course health development. Moreover, although the baby makes a late appearance, an estimated 37% of all payments across this entire episode are attributed to the newborn. Particularly concerning is a rise in healthier and healthier newborns being admitted to NICUs, which Dartmouth researchers attribute to supplier-induced demand and the number of perinatologists and NICUs that are out there. So including the baby presents important opportunities to improve quality and to lower costs. Third, most programs left the hospital phase of care aside. This is concerning for many reasons. We want all stakeholders to row together. There is much inappropriate overuse during the intrapartum period, and health consequences of such matters as safely avoidable cesareans are considerable. Many experience disrespectful care at this time, which can involve harmful delays in needed treatment. And there are also major opportunities for cost savings, as about $4 in $5 paid on behalf of mom and baby across the entire episode cover care during this brief window. So payments should be rebalanced to enable better support and care during pregnancy and the postpartum period versus hurried 15-minute office visits as the norm. As noted, researchers have identified avoidable NICU admissions with harmful mother-baby separations, so we need to include the baby and the intrapartum period to address this. Fourth, a series of underused high-performing models are exemplary and should be fully integrated into the maternity care system. TMaH recognizes this and includes expanding access to midwifery care, birth center care, and doula support as required elements. And optional TMaH elements include covering certified midwives, certified professional midwives, and perinatal community health workers. These important forms of care have had a fragile toehold in our maternity care system, and it is hoped that strong integration in TMaH will lead to increased resilience and access to these models. Also, past maternity APMs did not seem to go all in on quality and may have prioritized and in some cases achieved modest cost savings. It's clear that limited cost savings and QI are possible from nickel and diming Medicaid payments. Instead, we propose that going all in on quality can result in considerable cost savings. So just think of the short and long-term personal and financial costs associated with such all too prevalent conditions as preterm birth, untreated perinatal mental health conditions, avoidable trauma, suboptimal or no breastfeeding, high rates of cesarean overuse, and unmet social needs. We can do better in all of these areas and more, and should refuse to accept the status quo. But in a case like this model, we will need actuarial models that capture the benefits and cost savings of improvement in these areas and work in tandem with other design elements to achieve the system's potential. Advancing equity is an important dimension of quality that is fraught in the present environment. Dismal outcomes, especially for Black and Indigenous moms and babies, waste lives, potential, and resources. But the tools are at hand to make a difference, including diversifying the workforce and providing culturally concordant care, greater roles for CBOs, zero tolerance for disrespect and mistreatment, whole person care, addressing mental health and social needs, and reliable access to the previously discussed high-performing care models, including community-based versions of these models. To the extent that we can, or when we can, measure inequities and hold systems accountable for improvement, there is so much to gain for adversely affected communities and all. Given the demographic transition, this is a matter of respectful, responsible care and support, as well as population health. Next, please. Here are a few more examples of what we can do within and beyond TMaH to turn things around for childbearing families. So maternal and newborn deaths are catastrophes, and as Deborah noted, the great majority can and must be prevented. Whereas mortality affects a small fraction of the childbearing population, other consequential outcomes impact a very large segment of this population, and these include mental health conditions and failure to provide effective treatments, unmet social needs, including things like paid leave and issues with food, housing, transportation, and more, disrespectful and traumatic experiences, inappropriate care, including too much too soon and too little too late, inadequate supports for breastfeeding, and lack of information, choice, and shared decision-making processes. Many stakeholders focus primarily on maternal mortality and treat AIM bundles as silver bullets. Yes, we must avert catastrophe. However, getting out alive is the floor, not the ceiling. And we won't solve our maternal health crisis without moving upstream to provide more holistic and respectful care that enables our families to thrive. We were surprised that so many APMs set standards with ill-chosen performance measures. To limit the burden of collection and reporting, every performance measure should have the potential to drive meaningful population-level change. Yet many of the measures used in past APMs were not fit for purpose. For example, chlamydia screening in women is not central to maternity care. Severe obstetric complications involves events so infrequent that making sense of year-over-year progress is a challenge in many settings. The maternal morbidity structural measure is so easy to obtain as to be meaningless, and elective delivery is topped out. By contrast, other measure concepts are priorities, those relating to mental health, social needs, respectful care, cesarean birth, and breast milk feeding, address consequential and improvable matters impacting many. Accountability is at the heart of APM, so we were stunned to learn that shared savings payments do not standardly impact revenue of care team members. Just one program reported a requirement that at least 80% of shared savings reaches the care team. Apparently, it is widespread for the entity providing care to retain all of those savings with no financial accountability signal going to those actually providing care. So we think something like 80% to the care team and 20% for administrative costs would be a fine standard practice. Harold Miller of the Center for Healthcare Quality and Payment Reform has developed the concept of standby payments, which none of the programs we examined appeared to use. Standby payments end the fee-for-service reliance on volume by spreading the cost widely of having a service available, and then are complemented with standard payments for services that are provided. They recognize that many benefit from having a service available, whether they use it or not. Standby payments can support retention of services in rural areas. And among other potential maternity uses for standby payments is to support the availability of NICU services, so this can avoid NICU admissions of babies that are unlikely to benefit. Lastly, we believe that benchmarks should be increasingly stringent as care teams learn and improve. For example, the cesarean rate, which has been too high and essentially level for more than a decade, can safely be much lower, but goals should change incrementally, allowing teams the time to learn and implement the many evidence-based practices associated with safe cesarean reduction. Next, please. So we have a companion health affairs forefront blog for this project as well. It discusses the potential of TMaH and available resources. And in addition to the playbook, our TMaH landing page provides access to a TMaH fact sheet, an issue brief encouraging advocates to become involved across the entire cycle, which we also recommend for clinicians, and the health equity plan section of the playbook pulled out as a separate document. And the URLs are provided here. So next and last, thank you for this opportunity, and I'm happy to shift to discussion and questions about these topics.
Thank you so much. I really appreciate that. If you would all just, whoever has questions, if you would just add them to the chat, that would be great. And then, because we do have time for quite a few questions. I really appreciated the broad overview. I also appreciated you bringing in some very specific examples around some of the strategies that are being promoted, in particular around payment reform. So I am wondering, in doing culture shifts and the support that the work to increase, doulas and midwives and other care providers with who come to birth with a physiologic mindset around physiologic birth. Are there also a part of this, like workforce education, like expanding the workforce with these skills, or is that something that each state will decide how to build out those skills among the workforce?
So that is a great question, and CMS has a series of subcontracts with various groups across the country. I know there's one with Coral Health Advisors, with NORC, the National Opinion Research Center, and with Mathematica, some others. And these are tasked they have various responsibilities, but Mathematica is responsible for providing technical assistance for all of the elements except for the payment reform. And Coral Health Advisors is tasked with providing technical assistance for the payment reform. So there will be lots of opportunities for states to work together, and we'll see if they will be able to do kind of collaboratives as well of becoming familiar with one another's work and learning from those from other folks. I think it's all kind of unfolding now during this the initial months of the model.
Well, would there be, I think the payment adjustments, so each state will be able to set up their own payment model for their state. Is that, and adjustments to that payment model? And so they'll innovate within that payment model. Is that what I'm understanding?
Yeah, so the plan is for a single payment model that everybody uses, and
Okay.
that's they want to do that too.
That's why Coral Health is like helping in that regard.
That is correct, but as we know from our state work, states have very specific environments that
Right.
might not permit, for example, from a regulatory or statutory point of view, some of the aspects. So I think that what will play out will be an attempt to have some broad, basic elements, recognizing that there needs to be some variation but from state to state by virtue of constraints or what those environments offer.
Great. I have another question, but I'm wondering if I don't see any questions coming in. Please feel free to chat in your questions. Normally we get lots of questions, so people are being pretty quiet. But not to put you on the spot, and but maybe I will anyway. But as of on July 4th, we all know that the One Big Beautiful Bill Act was passed into law. This is a $1 trillion shift in health policy for our country, and it included significant significant adjustments in Medicaid and the Affordable Care Act. I know right now that there's, honestly, I didn't look at this moment, about government shutdown, but I know there's the big debate trying to pull back some of those budget cuts. But I'm just wondering, so does this initiative, does TMaH is separate from all of that? And how do you think Medicaid, shifts in Medicaid funding at the federal level will affect at the state levels? And I know every state's different with Medicaid and how it gets rolled out, but just wondering if there's been any conversations or anything you can share with us around that.
Yeah, so thanks, Deborah. That's really an important consideration here. The Innovation Center at CMS did modify some of their models at the beginning of this administration, but so far it seems that TMaH will stand, although I suspect, as noted, that the health equity requirement will just be cast aside for now. Clearly, the attacks on Medicaid will compromise the availability of people in state Medicaid agencies to, be engaged in this model. And they will compromise the number of people who could benefit from this model because there are predictions that access will plummet in significant ways. So that is an unfortunate occurrence at the beginning of this 10-year model. I still think there's a lot of reasons to be hopeful and a lot of reasons to pilot these concepts and ideas and try to move forward in shaping up our maternity care system in ways that haven't happened to date.
Yeah, and I'm still hopeful, like maybe there will be some pushback on some of this because we have research that shows that work requirements, for example, for Medicaid they just increase administrative costs and don't really help save money in the end. And then people are not, it's based on this assumption that somehow people are, not wanting to work, and it affects a lot of maternity patients. Anyway, so thank you for that, responding to that question. We have a question from Renata. And she says, in regards to adding more stringent designation requirements for birthing-friendly hospitals, what other specific factors and criteria of consideration have been recommended to be added? And then she has a follow-up question. So,
Um, I was not involved in this. My colleague Nan Strauss represented the national partnership. There was a technical expert panel convened by Yale Core. That is an acronym, and I can't tell you what CORE stands for off the top of my head, but they had a work group that came together and made recommendations. And they recently have called those folks back, and I cannot tell you the current status of it. It's unclear whether the current administration will continue it's kind of toxic in this administration, whatever was begun in the last administration. So I have no idea what the plans are for actually implementing those. But certainly the topics that I mentioned that would be great for performance measures of like cesarean overuse and breastfeeding and social needs and maternal mental health, all of those would be great things to add to the criteria to make it more stringent and to give a signal to people trying to choose care about what is a higher or lower performing facility.
I think your point around what's going to have the biggest impact on the population and mortality being this very, it's an important measure, but we need to also have broader population health-based measures as well. So, and Angelica, she's a doula, Region 9, Michigan. She said, its CORE stands for Center for Outcomes Research and Evaluation. So, back to the second question Renata asked is, how are the outcomes around equity for women of color being evaluated and used to gauge the efficacy of the model, or is it just centered on the number of live births and birthing outcomes?
So the final performance measures have not been announced, but and I could say, like, my reading of the director of the Innovation Center at CMS, or I guess director is his position, is that he's very interested in having these models be effective. He holds a set of values that would differ from some of those that I think many of us have, that focus on individual responsibility, for example, as opposed to structural factors. But nobody has really stated and showed their hands about what they've heard from CMS, but I feel that health equity is just not going to be in view in this model at all. I feel that everything we are seeing from the administration, and I think it would threaten the success of the ability to carry out the rest of the model for the director, even if the director felt it was important to focus on health equity. It would draw attention in this environment. So I don't think that we are going to be having, from a central point of view, this idea that we should be able to measure the subgroup, how they're faring, and set goals for improving those situations. Now, individual states may be able to do this within their programs, and certainly I think states not participating in TMaH have better options for this. But within this federally led program, I think that is probably not going to happen.
And I would say this is where I think using a QI approach makes it less about, it's about just following the data, where how are we going to improve health? Overall, we do follow the data to say, well, here's a group of people that are having the worst outcomes, and how do we help that group? And then, so we can, I like your title, like outcome gaps, like where are the opportunities for improvement is a way to still continue to address equity without having to get any, I don't know, it bothers me to even say what I was going to say, so I'm not even going to say it. But anyway, it's just like work on the problem without worrying. Let's not get hung up on words sometimes. But on the other hand, I use equity everywhere. So I talk about it all the time. All right. Well, this is, yeah, so I appreciate everyone's comments. I appreciate you coming. I will just put in one more plug around the Create Ripples of Hope documentary film project. We have a short film, a 15-minute film that you can watch and you can share. It's a hopeful approach to improving health equity and in improving population health overall. And Dr. Sakala, thank you so much for your work and your insights around the TMaH initiative for our country, and really excited about where this heads for the future. So thank you all very much and have a wonderful rest of your day.
Thank you.